in terms of both patients and providers, among those who are involved in opiates, you have those who are appropriately using, and we need to ensure palliation and appropriate care for people, for example, with intractable cancer pain. You have a second group of patients or physicians who may simply lack adequate training and information and be prescribing inappropriately or demanding inappropriately. Very interesting article last month in the Archives of Internal Medicine that looked at patient satisfaction and patient outcomes. More satisfied patients used more health care, used less emergency department visits, and died younger. It's not always the best thing to give patients everything they ask for, particularly if those are addictive substances. And then there are a very small number of patients and a very small number of doctors who are breaking the law and are doing this for profit and essentially are drug pushers. And for that, you need the appropriate law enforcement response. Hal Rogers has been really a leader in the fight against prescription drug overdose. He rang the alarm early, and he's been a leader in helping to get the programs up and running around the country. We need now to optimize them, implement them, and ensure that we can make them effective at confronting this epidemic. The failure of prevention costs money. As I said earlier, someone who's got obesity costs about $1,700 more to care for per year. A smoker costs about $2,600 more to care for per year, and someone with diabetes costs about $7,400 more to care for every year for the rest of their life. There are scalable interventions, and one word I want you to take away from this conference is scalability. Having an intervention that works great in a small group but is never going to get scaled up is not having an intervention that's going to do the kind of good it could do. The diabetes prevention program can reduce the risk of progression from prediabetes to diabetes by nearly 60%. Working with the Y, we've been able to drive down the cost from $2,000 to $400 to $500. And if you compare that with the $7,000 plus cost of diabetes care, you realize that this can be a cost-saving intervention. In fact, nationwide implementation of this would break even in about 14 years and provide billions of dollars of healthcare savings soon after that. Just to give an example from the past of fluoridation, fluoridation reduces dental caries substantially, saves about $20 for every dollar spent, and is highly effective to reduce costs. Folic acid is another area where there's been real progress. More than a 1/3 reduction in neural tube defects, preventing an estimated 10,000 children born with neural tube defects, and saving more than $400 million in healthcare costs alone each year. We have more to do with neural tube defect prevention, particularly among Hispanic women, and we're working with a company which has just submitted its proposal to the Food and Drug Administration, which has to approve it, to fortify corn masa flour, which is more commonly used in Mexican-American communities and will result in a further decline in neural tube defects in that population. We need public health systems and services research. Prevention can improve health, reduce disease, and save money. We have many missed opportunities to improve health and save money in healthcare. We need to identify and document cost reductions, and we need to identify how we can deliver the strategies that we identify at the right time to the populations most in need in the right way every day, year-round. The challenge is to identify the scalable interventions and then to scale them up. And doing that will require establishing feedback loops, figuring out what works, figuring out if we are going to scale, if we do have fidelity to the model, if we are achieving the impact that we are anticipating that we will achieve. I give the example of my experience as a health commissioner in a large city where We implemented tobacco control interventions. We increased the tobacco tax. Smoking went down. We implemented Smoke-Free Air Act. Smoking went down. We then thought our job was done, but smoking then didn't go down anymore. We had a stall. So we said, what else can we do? We ran hard-hitting ads, and again, we saw a dramatic decline in smoking. If we hadn't had that feedback loop, we wouldn't have known that we needed to do something different. We wouldn't have achieved the results we did. And when we were criticized for spending that kind of money on hard-hitting ads, we wouldn't have been able to defend them. But I was able, because of the information systems that we had, I was able to say under oath that I was confident that the ads that we were running were saving at least 1,500 lives for every $1 million we spent. And I think the life of one of our fellow citizens is certainly worth the modest investment that that represents. So bridging the implementation gap is the challenge for health services research and for public health research. We have knowledge and technologies, things that we know work, and we have the ability to implement. But what we all too often lack is the connection between those two things. We have an implementation gap. The gap between what we know and what we wish we knew is huge, but it's much smaller than the gap between what we know and what we do. And that's the challenge of all of us working in implementation research, health systems research, and public health implementation, because ultimately there should be no gap between program and analysis. It's not a question of analyzing over here and running a program over here. A well-run program must have an inbuilt feedback loop to figure out if it's working so we can defend and extend programs that work and fix them if they're not. Thank you very much.